Give a little qualifier that Dr. Lozano, who I'm sure many of you know, is the one who really got me started with IlluminOss. But since he got me started on it, I've started using it for all kinds of things. And in a really high volume center like University of Miami for metastatic disease, we have found it to be a very, very useful tool, especially that it's minimally invasive for our metastatic patients who are otherwise unstable or not medically able to undergo a major surgery. So these are just some of the things I've done a lot of IlluminOss in the last year. And these are just some things, some tips and tricks that I've sort of experienced myself. So if I can help anybody not go through the struggle that I had, or have had, not every case, but some of them, then we will have made a successful educational little session tonight. But really, this is a really great option for the very sick patients because it's all percutaneous. I do it under general anesthesia. I've had IR people reach out to me to see if they think they could do it. So far, I have not even sort of opened up that can of worms because I like doing these. And you'll see some of these require more than what an interventionalist would be able to do. Originally in the upper extremity, especially we're talking humerus is the most common location that I tend to use these. I started by placing derotational screws through the IlluminOss above and below the fracture. Having done several of them now with patients who are reasonably sick, I have found that that is not necessary. I'll usually do a live fluoro to check that it's rotationally stable. And in every case that I've tried that, it has been. So that's just one thought. I still check them rotationally now, so I'm not sure I've fully convinced myself, but I do tend to not put the screws in more often than I do now, than I used to. And these are really, really great for the metaphyseal proximal humerus lesions, or with lesions that would be sort of at the tip of a normal humeral nail distally. Anything in the diaphysis in between, I tend to use a regular nail still. It's not that much bigger of a surgery for a normal nail compared to this, which in some of the other bones that's a little bit different. So for in diaphysis, I still tend to use the regular nails. I'm not sure that IlluminOss offers a huge advantage, but the proximal metaphyseal fill is amazingly different, and I think that's where we get our rotational stability. This is an example of one of my cases. This is a patient who was very, very refractory multiple myeloma, came in with several fractures. I think we did recon nails on both of her femurs, did IlluminOss in both of her humeri, and then she also had a proximal radius fracture. And so we did, I think, all of the IlluminOss in one day plus a femur, and then came back and did the second femur later. But you can kind of get an idea of what I'm talking about with the fill, especially over on this right-hand side of the screen. That metaphyseal fill, unless you go in with a nail and curettage and cement around it, you just don't get it with a normal nail. And again, you can come all the way down to the end of the cortices and the canal with an IlluminOss. If your lesion tends to be a little more distal, then you could probably with a regular nail. You can also ream down a little bit further. The reamers are not super thick, and they aren't super aggressive. So you can give yourself a little more of a canal if you need it without worrying about damaging the normal bone. This patient unfortunately succumbed to her disease, but we were able to at least make her weight bearing in all 4 of her extremities prior, and she was much more comfortable. Pelvis, I say sloppy lateral is easiest. It just sort of depends on the tumor and where it is. The body habitus, the anterior column or superior ramus nail can be quite a struggle. The first one that Will and I did here with my local rep, Brandon Lopez, we battled a huge body habitus in the gluteal region, and I had been trauma trained, and so I was trying to go, from the posterior excuse me, the posterior gluteal outer table of the pelvis and bypass an area that had no bone left to it from a met with several inches of soft tissue in between, and it really just didn't go well. So I actually called Dr. Lozano about that particular case, and he said, just close everything up, flip her over, put her supine, and gum from the pubis. And that's what we did. And she actually had a really good outcome with it. But with the body habitus, the pubis start point is crucial for success and not feeling really, really tired and bad about yourself by the end of the day. Removing the light source is fine. Like, it's a threaded intramedullary thing. So this is more about removing the cannula that the light source goes through. And, you know, again, if you're in a deep patient, those little, they look kind of like a Craig's needle, since probably several of you are orthopedic oncologists. You know what I'm talking about with the serrated end. And they're supposed to dig into the nail and break off the cannula that the light source is to. But I've had several be retained and had to make bigger incisions to trim them down a little bit further. So that's been one of the more frustrating parts of this for me. Although I think we have gotten better at it as I've practiced. The other thing that Brandon and I sort of came up with, I really liked being able to use the thin ball tip, because we could pass a cannulated drill over it, but the thicker ball tip, which is much heftier in terms of getting it through sclerotic bone or getting it to actually bounce off a cortex instead of bend or break. We really needed a 6.5 cannulated drill with that, and that's been working wonderful. And the reamers are also just side cutting, and I think I said this already, but they're very gentle. So the drills are actually an important backup, and your large ball tip will go through the 6.5 cannulated. So you can use that. You just have to use a little more fluoro because the ball tip won't stop you. These are some of my cases. This is a bilateral breast met patient. This lady, again, sort of end stage, very uncomfortable, very painful walking. And we were just trying to give her a little bit of quality of life. And so she got bilateral, both sides, all 3 nails. And again, she succumbed to her disease, but she was reasonably comfortable when she passed, at least from her pelvic standpoint. And then I have a couple more that are a little less standard. So this is a patient who had a prostate met to his quadrilateral plate that was radiated. And as far as we're aware, he is no evidence of disease at this point, and then developed a pathologic fracture through the radiated bone, probably more likely osteonecrosis. And so my fellow, I think he's on the talk tonight, and I went in and had sort of planned on just medializing this joint and not really using the standard tripod that we would do for the pelvic mets, but really just trying to fill in the acetabular area that we had lost. So these are just the other CT views. And we did have a 3D recon, which I'm not always great about asking for, so I was excited to have that. But this is essentially what we did. We made a nice big exposure posterior approach. We visualized the entire acetabulum, 360 degrees. And then we passed the IlluminOss. We had one larger balloon in front of this smaller balloon up at the top. Those were the 2 areas visually that we thought needed the most fill. And what's awesome about these, if you guys haven't done it yet, is you can put hardware through them. So, and you can ream through them. So you can see this is the nail reamed with our acetabulum. We had good rim fit with him as well, which was why this ended up working out. And then we packed sort of posteriorly here with osteocrete. And so this is what his post-op images looked like. This is the IlluminOss sort of filling in that medial portion of the acetabular bone loss. And these are his post-op x-rays. I just spoke to him again yesterday from clinic. He's in rehab still and doing well walking. He's just having a hard time getting into physical therapy because of his health insurance, but he's doing really well. And those were his post-op films. This was a patient who had newly diagnosed metastatic renal cell. He was incredibly sick when we met him in clinic. We had to admit him to the hospital from clinic. I think he had a humerus nailed and a femur nailed before we did his pelvis. So he had a pre-op embolization for his pelvis, and then we put in the normal tripod of the IlluminOss nails, which, if nobody understands what I'm talking about there, please feel free to ask at the end. We're happy to go over it with you. I think it's been well described by Dr. Lozano in the literature. And my fellow, again, who is here, so I can feel comfortable teasing him a little bit. He really likes hardware still, because again, he hasn't really used IlluminOss before this case. So we added a screw here, and everything went pretty well for him. He was up and walking, went home, and maybe about two 2 or 3 weeks post-op, slipped and fell onto his right side. And even though you can't see it on the general x-ray, you can see it on his axial CT scan where he actually developed an acetabular fracture. But when you look at his post-fracture x-ray, he maintained his continuity of his joint and kind of a secondary congruence because of our tripod. So we were actually really happy with that, especially because he had been so sick in the first place. We weren't really comfortable taking him off chemo and providing him with a bigger, more stable operation at this time. We really think he needs to get control of his disease before we do anything massive with his pelvis. This is another patient of mine who had had a cementoplasty for breast cancer mets that were higher up in her ilium, and she had developed hip pain after her cementoplasty. I think this had maybe been done about a year to 18 months before I met her. And you can see she did have some failure of her subchondral bone. I don't know exactly when this occurred for her, but the cement was actually intra-articular. And when we went in there, we essentially approached her like a normal total hip, exposed the acetabulum, which this is one slice above the actual joint line. And you can see she also had a fracture with it. And so we kind of opened up this area, got the cement out, and then put the IlluminOss in a tripod range. This is a pretty vertical cup. I wanted to make sure you all knew that I understood that. And so I put the measurements there, but she was very stable intra-op and she's doing quite well as well. And her versions are maybe not the greatest either, but again, very stable and she's happy. So I'm happy and we'll keep watching her. The one caveat I'll say to the pelvis is if the acetabulum, the subchondral bone, is sort of comminuted or with congruency, or there's some tumor there, it looks really moth-eaten on your axial imaging. After reaming and placing the nails, what I have found is patients do really well for a few days or even a couple of weeks after surgery, and then that subchondral bone will collapse on them. And I don't know if it's the reaming, I don't know if it's tumor progression, I don't know exactly if it has anything to do with the surgery, if that was going to happen anyway. But it's gotten me to a point where if the patient is someone who can undergo a bigger surgery, I would prefer to do the total hip with the IlluminOss at the same time. However, a lot of the patients, like I said, have been sick enough that we've tried it. We've essentially chanced it with the IlluminOss alone, and we've gotten away with it about maybe 50% of those cases. I've also had a femoral head collapse. That one is a little bit different. That one, the tumor was invaded into the joint line. So again, very sick patient. And we had to go back and put a total in her as well. So this is a hepatocellular cancer patient. It was really sad. She had actually had a liver transplant for her liver cancer like 8 or 9 years prior to presenting to me. We had biopsied her, showed that her tumor was back, not in her donated liver, but in her bone only. And you can get an idea of this sclerotic met in the subchondral area. Her femoral head doesn't look entirely normal either. So whether or not I would have called that arthritis in retrospect, maybe that's what I was thinking. We put the IlluminOss in and you can see she just sort of medialized right through that area. And so we came back a few days later, but now had more bone loss. So I do think her tumor actually progressed, which may have contributed to this. And we had to do some pretty wild reconstruction, but we did absolutely use the IlluminOss, especially the LC2 and the posterior column in helping us reconstruct her hip. Doesn't look as pretty there though. And then this was a case I did out at UCLA before I moved here. This was a patient who had a painful, mostly soft tissue clavicle met from a renal cell. And we opened up the met, curettaged it out. She was very tender to palpation. And then we put the IlluminOss in. It was a little bit tricky just because of the curvature of the IlluminOss. So we actually put it in from the fracture site, kind of like one of those old K nails where we popped it out laterally, reduced the fracture, and then threaded it across the fracture site. This was her immediate post-op imaging. Because I moved from UCLA, I didn't think, I wasn't great about gathering all images, but actually in a post-op CT scan about 3 or 4 months after this surgery, and after this x-ray, she had become 100% displaced and the IlluminOss had sort of bent at the fracture site, but the patient had no idea of that. She just ended up with essentially an imaging finding, and her pain was gone. So we didn't really count that as a failure for her, but it was more of an interesting, can the weight of the arm really, or can a little 9 IlluminOss really hold up against the weight of the shoulder girdle? And it turns out probably not. But the patient felt very, very good. And so really that was the goal that we tried to accomplish. Those are my main cases. I may have gone a little bit fast because I tend to be a fast talker, but I'm happy to take any questions.